while Libby gets this set up, I'll just say, speaking here is like, it's like playing basketball at your home court. Enthusiastic and hopefully forgiving fans in the audience. So Pam asked earlier the staff of CHHS at Cal Ohio to stand up. There's a wonderful new team there, as you saw. It's been fabulous working with them over the past few months. In the midst of this transition, their support and dedication has really got us through. I would also like to acknowledge my colleagues at Cal eConnect. If you could stand up, please. We have a great team today, and we're excited about transitioning to UC Davis. Wait, stay up. And let's also have any board members of Cal eConnect or members of our advisory groups or work groups, or if you participate in the community of practice, stand. Great. So you can see here, Cal eConnect is underneath my name. That will soon be changing, as you heard earlier today. Don't forget, if you have ideas, if you're a branding guru on the side or hidden within you, take this opportunity to send UC Davis suggestions, and hopefully you will have the winning entry. I'm talking today about HIOs and the adaptive path of HIO development. In my role at Cal eConnect, I work with HIOs throughout the state, and look forward to sharing and then discussing with you their sort of current state and their plans for the next 18 months or so. I want to start with an observation from the natural world. We know that in dynamic natural systems, the only constant is change. But amidst this change, there are recurring patterns across scales. And this is manifested visually in many ways. For instance, the pattern of veins on a leaf, or branches in a tree, or veins in one's body. Or here, this is a river system in China. Just as so life forms adapt to and can grab on to these patterns amidst change. In human social and economic systems, there is also constant change, and as well as recurring patterns that I believe cross scales from the individual level on up, and that I will use that analogy loosely as we move forward. Let's see if it works. So we know that there are some multiple patterns driving demand for HIE. I don't need to go into detail here. We're all aware of them. Transitions of care across fragmented systems, the need to deliver more efficient care, and as Lynette Scott discussed earlier this morning, and John Blair just now, as providers adopt EHRs, one of the first things they ask is, okay, now who can I exchange data with? And they don't want to be restricted to providers in their EHR silo. They want to exchange data with a specialist down the street, in the hospital a couple miles away. They're on different systems. So if HIE is poised for tremendous growth, what about HIOs? That's what we'll talk about today. How are they adapting to the emerging landscape? What value will they deliver? Let's start with some definitions. And so I'm choosing here to use the term HIO, Health Information Organization, instead of the noun form of HIE. I think it doesn't really matter, but we're working with this term. I think HIOs have two primary components. They provision HIE services, and they provide a governance function, which is in contrast to a HISP, a Health Information Service Provider, or a vendor. And so HIO governance is typically at the local level in a medical trading area with a high volume of patient referrals and flow, and is nested within larger sort of state and national frameworks of regulation and oversight and governance. So how to slice and dice up to categorize HIOs? There are multiple ways, but as we've heard today, from several speakers, one common way of thinking about HIOs is community HIOs on the one hand, which enable exchange across unaffiliated partners. Typically, their governance is they have a governing board. They may be a 501c3, and participating members are on the board. Enterprise HIOs enable exchange within private enterprises. Their governance is provided within existing structures. And interestingly, they also, I've learned, been learning, we often assume that a large sort of enterprise, their HIIE effort is for sort of uniform data flow across their entire system. That's not the case. They, as well, often take a regional approach. For instance, Dignity Health, and Sean is here, we talked about this last night. There are 10 regions within Dignity in California, and their approach to HIE has been sort of region by region with some sort of global overlay, but governance often happens at the regional level, which creates interesting opportunities for collaboration then with regional community HIOs as well. So other permutations, if you think about ACOs, they require health information exchange among their partners and also governance. So you put those two together and they can function as an HIO and make contract with similar organizations that HIOs do to make that happen. So community HIOs, let's talk about them for a couple of minutes, have been written off before at several sort of points in sort of recent history. There is one narrative that the conditions in the environment today are just simply too inhospitable for their survival and that they will become extinct. Now, the conditions in our environment are not necessarily sort of a storm of asteroids and a subsequent ice age, but nevertheless, we all know that community HIOs do have an uphill climb, and some have feared that it's just too steep. Another public health announcement for the day. Courtesy of Gary Larson. My 7-year-old is now reading The Far Side. It's frightening, translating these things to him. But so there's a similar sort of narrative that Mickey Tripathi just sort of, I think, very articulately expounded upon, which is that HIOs often bring it on themselves, essentially, and the most common cause is over-architected solutions. Over-promising and under-delivering, and eventually collapsing under the weight of expectations that can't be met. So what really are the threats? Well, and challenges for HIOs. There have been, there are several potentially threatening models that folks have reacted to and adapted to. One is EHR vendor-based exchange. The large EHR vendors, as we all know, are enabling HIE with their within their sort of client sort of silos. Direct, when ONC first announced and promoted Direct, HIOs at the state and regional level, there was a lot of questioning this strategy from ONC. Are you trying to kill us off and by enabling unmediated exchange between providers? It's turned out that actually HIOs are now at the forefront, as John Blair described in his case, of using Direct in really interesting ways for interesting use cases, both for exchange between providers and, as Rim Cothran, our CTO, will talk about a little bit tomorrow. Well, he may not talk too much about Direct, but enabling exchange between HIOs. Ongoing challenge. Oh, single statewide infrastructure, not doing that in California, but there has been concern that single statewide or national infrastructures could obviate the need for regional exchange. Ongoing challenges, we know about challenges around a trust framework and such that regional governance can be nested within sort of larger structures and have clarity on what's happening at the state and national level. A lot of work being done in California, led by Cassie and her team there. And then stakeholder and vendor dependencies on vendor timelines and say interface costs and stakeholder timelines. And then issues around resources, cost structure, and sustainability. I'm not going to talk about sustainability, but I want to do a little exercise here that I think shows challenges with resources today. Now, I'm proposing a measure to NQF. No, I'm joking. But on staff to board ratios. And I think HIOs ideally are naturally sort of nimble organizations with a lot of in-kind sort of sweat and blood by stakeholders, which is as it should be. But there also needs to be sufficient staff resources to get the work done. So, for instance, at eConnect, over our 2-year history, I think the ratio has been about 2 to 3, 2 staff members per 3 board members, one of whom is sitting right here. If you add in our advisory groups, it's been about 1 staff member per 10 board members or advisors. community HIOs in California. Now, I think the range would be from about 1 to 3 to 1 to 1. So 1 staff member to 3 board members, maybe 2 staff members with a 6-person board, or 1 to 1. If anyone is part of an HIO in the state that has more staff than board members, let me know. So the message here is that there are limited dedicated resources to meet the objectives set by volunteer governing boards, and this is really having a very real effect today with the organizations that we are working with. Let's do a quick, well, and these numbers are not, are somewhat skew the picture because we know HIOs work with many consultants and contractors and vendors. So let's do a quick poll. Stand up if you work for, if you're staffed full or part-time for an HIO. Okay, a few people. Now stand up if you are a vendor, or no, stay standing, stay standing. If you're a vendor or a consultant or contractor and you're currently in the budget for an HIO. Okay, a few more, excellent. But sparse, okay, go ahead and sit down. Now stand up if you're on the board of an HIO in California. Now this might prove me wrong, we might be a staff heavy conference. Okay, there's my, okay, so we have a few board members. What if you're on an advisory group or a committee? Stay standing, an advisory group or a committee of an HIO in the state. Okay, so we're about 50-50 here today. I think that then that's sort of what we're seeing. Now for a completely unfair comparison, IBM, 31,000 employees per staff member. I think one of them, Rena, is somewhere around here. And yet, in spite of these constraints and the threats, the perceived threats that we talked about earlier, there's more HIO activity and investment in California now than ever before. So I don't think the question is, will HIOs survive? Will that basic model survive of governance plus HIO services? Rather, which HIOs will survive? What forms will they take? How will they deliver value? And how will they interact with each other? And on the sort of cautiously optimistic side, I mean, the good thing here is these are questions that one might ask of any dynamic market. So we're in good company. I want to run through some data that we have gathered with a consulting firm, Top Tier Consulting, that did a survey and interviews with HIOs in the state in February and March. So this is already somewhat outdated, but it's the best we have. And we have to treat these numbers with care, and which I'll explain in a second. We interviewed 13 community HIOs, 14 enterprise HIOs that were willing to participate and represent the lion's share of HIO activity in the state. This represents, this table shows their projected patient sort of populations served for by the end of 2012 and by the end of 2013. Let's just look at the bottom line for 2013. It's like 13 million served by community HIOs, 13 million by enterprise HIOs. And there's some overlap here, so these numbers, if you add you can't just add the total together and get to 26 million Californians. But just because, and these are aspirational numbers and must be treated with caution, just because someone is in an MPI, an HIO's MPI, also does not mean by any stretch of the imagination that doctors are accessing data on them or exchanging data on them. So we'll be working with UC Davis moving forward to develop and gather data at the transaction level to really have a better picture of current activity. But the key message there is there are a lot of really ambitious organizations in California, HIOs, who are dedicated to seeing this work through. Here's a map. I'm going to show a couple maps. These are sort of self-projected HIO locations by the end of 2012. And the survey asked folks to name the counties in which they would be active. So they might only be active with one facility in a county, and they get the whole county on our map. So treat, it's should be discounted, but it shows a couple of things. I think first that there's clearly a lot of activity on both sides of the fence. There are five community HIOs centered in large urban areas that in counties that make up 74% of the population that are all going live this year or already have, and that's south to north UCSD, the San Diego Beacon community, Ocprio in Orange County, Lanes in LA County, Healthshare Bay Area, and what's IEHIE, Inland Empire, HIE. You can also see And let's just move forward to 2013. So we can also see that the enterprise HIOs, they're the little dots. And I know you can't really, it's hard to see what's going on this map, but check out the thumb drive later. And hopefully, I hear Davis has some advanced mapping technology beyond Microsoft Paint, which is what I think Rachel used. So the enterprise HIOs, there's been discussion today about how are they connecting with community HIOs. And are these parallel tracks, a sort of digital divide in California? And you know, it's glass half empty, half full, but many of the larger community HIOs do have participants that are facilities and part of enterprise HIOs as well. So HealthShare Bay Area, Sutter and John Muir are involved there. San Diego, Sharp and Scripps, Orange County, there are numerous hospital-based enterprise HIOs that they're leveraging. Let's see, Inland Empire is doing exchange via Connect with, or is planning to, with Kaiser and Dignity. So I think we're seeing increased interest among the enterprise HIOs in engaging with community HIOs so they can have better data on their patients as they move outside their systems. And this is something that we really, at a policy level, want to encourage over the next year. St. Joseph's Health System is an interesting case. They have facilities in 3 counties where we are funding expansion grant efforts. In the north, Humboldt County, here with Redwood MedNet, and in Orange County. And St. Joe's is fully participating in each of those efforts. And as they mature, it'd be great to have Jeff Alport give a talk on how that's impacting their larger health plan integration. I'm sorry, health system, the integration of the care that they deliver. So the last thing I want to say about this map is it's clear that the community HIOs are, their service areas are, they're more cheek by jowl than before. They're rubbing up against each other, and there are overlapping service areas. But once again, from a state policy perspective, I think we want to encourage this. We don't want to, from on high, carve out monopolies throughout the state. We want consumers of HIO services to have choice, and it will be, it will be very interesting to watch, see how that plays out. And I think there will be some, over time, a lot of growth and consolidation, and that's a good thing. Stages of development, based on the, the EHI stages of HIE development, we asked a question for, asked the HIOs to identify where they are. What's interesting about this is that, while there is more among the operating HIOs, there's much more activity on the enterprise HIO side. I think if we had transaction stats, it would just be through the roof relative to the community HIOs. But what's interesting is that there's about an equal number of, or ratio of operating to planning efforts among the enterprise HIOs as we're seeing among the community HIOs. Transaction types, well, the O&C priorities that we're promoting for HIE and that are connected to meaningful use are on the radar and in the production plans for both community and enterprise HIOs. You can see here lab results delivery, care summary exchange are near the top. And then, interestingly, I just want to point out to PHRs down at the bottom. Over the next year, it looks like, both on the community and enterprise side, there are a small number of HIOs that offer PHRs, but a large number want to in 2013. Whether that is being sort of adaptive to the evolving landscape and consumer demand or overreach, we'll see. I think it's great that they're thinking about it and connecting PHRs to at the HIO level rather than at the provider system level makes a lot of sense. So if imagine you're in a set of 3 counties in rural California that have a sort of coherent medical trading area. You want to do HIE, you've gotten folks together, maybe you'll form a nonprofit. What are your options? How are you going to make it happen? The classic path has been to contract with an HIE vendor and build and integrate a unique technical HIE sort of structure for your community. That is still one way. Well, that's labor intensive, and less of the new efforts, the planning efforts that we're seeing, want to go that route. They don't have the IT resources or to do it. So another option is to contract with a HISP, a health information service provider, which we're using that to not just, perhaps to O&C's chagrin, to not only designate service providers that enable direct, but that enable health information exchange more broadly. So basically, synonym with an HIE vendor. Although you could have an HIO that is a HISP, and that in its own sort of catchment area provides governance, but then sort of franchises instances of its services in other regions. And we think that that may begin to happen. And we know that there are already discussions along those lines. HealthBridge is doing that, for instance. Or you could join another HIO, or you could just do governance and set local standards and, set local standards and maybe even accredit HISPs for exchange in your area. User interfaces and workflow. I think we found that there's not a consistent path here. Often a web portal is an early component of an HIO's offerings, as a way for physicians to access data. And but web portals don't necessarily go away as an HIO is able to push messages into EHRs or pull data out. One use case, I was talking with Pablo Dio of Krios, one use case for a portal is doctors who are using iPads may not be able to access the sort of community data tab in their EHR on their iPad, but can get the same data through a portal. So we're seeing organizations sort of take, these are common elements, and obviously some are a little more advanced than others, but they don't necessarily sort of ditch the earlier stuff as they get more sophisticated. Once again, the concept of a digital divide in our healthcare system between providers and plans and other organizations that are more focused on the safety net and Medi-Cal populations, and providers focused on Medicare and commercially insured populations that have more resources and more HIT penetration. There are enterprise HIOs on both sides of that, and community HIOs are in a unique position to help bridge that divide. We're seeing that in the participation in the community HIOs in California. I think it gives them a stronger sort of market position, and from a policy-making perspective, it's also really desirable, and we want to support it. Finally, I'll conclude here with one example, which is Krios that I just mentioned, that I think pulls together some of the different themes that I've talked about and that we've seen today. So Krios had an independent stakeholder board for a couple of years and recently submitted an application for 501c3 status. Their approach includes multiple HIE modalities and a portal, as well as interfaces to EHRs. They're contracting with Mirth for their core HIE infrastructure, and they're targeting 100% of hospitals and providers for participation over a 3-phase plan by the end of 2013. So they're leveraging investments that hospital systems in Orange County have made in enterprise HIOs. Their first phase began with physicians in Monarch Healthcare, which has 2,000 physicians out of the 6,000 in the county. And also 1/3 of the hospitals in the county are part of the first phase. There's active involvement from the County Medi-Cal Managed Care Plan, CalOptima. It's very important in Orange County because there is no county health care system. That's all sort of mediated through CalOptima. But we are seeing the Medi-Cal Managed Care Plans as the first movers among payers in really being involved, getting involved with community HIO efforts. LA Care is another great example, or partnership up here. Currently, and then in the second phase, Krios hopes to collaborate more with the REC in the county to reach out to its 1,200 plus supported physicians and develop interfaces to the 5 sort of approved EHRs to reach those physicians. Currently, they're completing testing with Monarch in several hospitals, and initial live data exchange should begin in 1 month, pending the signing of participation agreements. Also not uncommon. So signs to watch for as we move forward, sort of gauge the level of adaptation of HIOs to the landscape. Do they have incremental plans, and are they making solid incremental progress? Are there any sightings of the hockey stick? I think Claudia Williams, I don't know if she's here, she might show a hockey stick tomorrow. The e-prescribing, which is a spike in adoption. And so metrics we're interested in are sort of signed agreements with participants, sort of a precursor measure, the number of exchange transactions, and patients in systems, as well as maintenance fees paid by participants. Are participants paying? And in some cases they are, in many cases they aren't. As we talked about earlier, staffing levels may also be important. In HIO competition and connection, we hope to see vibrant competition throughout the state, as well as connections and data exchange between HIOs that Rim Cawthron will talk about a little bit tomorrow. We're attempting to facilitate HIO to HIO exchange as a key component of interoperability sort of statewide moving forward. And finally, is there congruence across scales in the California HIE landscape? Are the activities at the national and state level reinforcing positively what's happening and needs to happen by HIOs at the regional level and providers in their organizations and individually? Look forward to an update next year with some hockey sticks to show you. Thank you.